In this video, we are going to cover flowcharts and tables from the topic of pulmonary hypertension. Pulmonary hypertension refers to mean pulmonary artery pressure of more than 20 millimeter of mercury, and this has been further classified into two types based upon where the pressure is increased. It could be precapillary or it could be postcapillary, and if both the findings are present, then it is known as the combined type, pre and postcapillary pulmonary hypertension. Now let us understand what it is. So here, suppose this is the right side of the heart. This is RA and this is RV. And here we have the left side of the heart. This is LA and this is LV. So from the right ventricle, we have the pulmonary artery. Then this ends into capillary, and from the capillary, we have the pulmonary vein, which is draining into the left atrium. So if the pressure is increased on this side, this is known as precapillary pulmonary hypertension. And the marker of precapillary pulmonary hypertension is pulmonary vascular resistance. This identifies the intrinsic pressure that has been built up inside the pulmonary artery, and this is calculated in Wood's unit, and the cutoff is 2. If the pressure is more than 2 Wood's unit, it means that this is precapillary pulmonary hypertension. Then, talking about this part, this is post capillary pulmonary hypertension, and here the cutoff is 15 millimeter of mercury, and here the pressure will increase if the pressure inside the left atrium is increased, that you can see from the diagram. Suppose if the pressure of left atrium is increased, this will be transmitted back, and here the post capillary pulmonary pressure will increase. So if pulmonary artery wedge pressure increases to more than 15 millimeter of mercury, it means that the cause is post capillary pulmonary hypertension. And if both the values are increased, that is, if PVR is more than 2 and pulmonary artery wedge pressure is also more than 15, it means that it is a combined type. Because in the chronic case, if the left atrium pressure is chronically increased, then this pressure will be transmitted to the right side also, and the remodeling of the vasculature will occur. So it will lead to combined pre and post capillary pulmonary hypertension. Now let us read the causes. So pre-capillary pulmonary hypertension causes are pulmonary artery hypertension, pulmonary venous occlusive disorder (CHD), or chronic lung diseases because of hypoxia, or chronic thromboembolic pulmonary hypertension, or multifactorial pulmonary hypertension. Now post-capillary pulmonary hypertension, as you can see from the diagram also, it is because of left-sided heart disease. Now coming to the mixed type. The causes are chronic left side heart diseases, chronic thromboembolic pulmonary hypertension, or multifactorial pulmonary hypertension. Now, coming to table 1, the World Symposium on Pulmonary Hypertension has divided the pulmonary hypertension into various clinical classification or various clinical groups. So, only per se the groups could be asked in the examination. So, group 1 could be remembered as the primary cause of pulmonary hypertension. The causes being idiopathic, further divided based upon vasoreactive testing into responders and non-responders. It could be heritable, it could be associated with drugs and toxins, could be associated with connective tissue disorders, likely SLE or scleroderma, commonly seen in the clinical practices. Then it could be because of HIV infection, portal hypertension, congenital heart diseases, cystosomiasis, or pulmonary artery hypertension with features of venous or capillary involvement or obstruction, like pulmonary vein occlusive disorder. Or it could be because of persistent pulmonary hypertension of the newborn. Then coming to group 2. This is the group where the pulmonary hypertension is because of left-sided heart disease. So I used to remember it as the left side of the heart disease has two chambers, right? LA and LV. So it belongs to group 2. So the causes could be heart failure with preserved ejection fraction or reduced or mildly reduced ejection fraction, could be valvular disease or congenital or acquired cardiovascular condition leading to post capillary pulmonary hypertension. Now coming to group 3. Group 3 is the pulmonary hypertension which is associated with lung diseases or hypoxia. So you can remember it as the lung has three lobes. on the right side, and on left side there are, although there is two lobes, but lingula is also present. So you can remember that lung has three lobes, so it is coming into group 3. So the causes could be obstructive lung diseases or emphysema, restrictive lung diseases, or lung disease with mixed obstructive and restrictive pattern, hypoventilation syndrome, hypoxia without lung disease, or development lung disorders. Now, group 4, this is a special group where the main or the common cause is CTEPH, that is chronic thromboembolic pulmonary hypertension. This was asked in the examination, or it could be because of other pulmonary artery obstruction. Then group 5, the etiology is unclear and it could be because of multifactorial mechanism. It could be because of hematological disorders like the sickle cell anemia or CML, or it could be because of systemic disorders like sarcoidosis, or metabolic disorders like Gaucher's disease or glycogen storage disorder, or chronic renal failure even with or without hemodialysis, or pulmonary tumor thrombotic microangiopathy, or fibrosing mediastinitis. Now, coming to the flow chart where the strategy for diagnosing pulmonary hypertension is discussed. So here, this is not a important flow chart. Here, you just need to remember that if that any patient is coming with the symptoms of dyspnea and you are suspecting pulmonary hypertension, first you have to take proper history, physical examination, look at the ECG, BNP, and oxygen saturation. And by this, you can easily tell whether the cause is lung disease or heart disease. And if it is lung disease, then you have to go for PFT, ABG, X-ray, and other investigation. For heart disease, you have to do echo, history taking, PET examination. And based upon all this examination, you just need to find out what is the probability of pulmonary hypertension. And if you feel that the probability is high, then you will refer the patient to the center who are specialized in treating and evaluating pulmonary hypertension. This is the only crux of this flowchart. So once you have established that the patient is having pulmonary hypertension, now let us treat this patient. So the first investigation that you need to do is vasoreactive testing, and commonly it is done with the help of nitric oxide. So you will give inhaled nitric oxide to this patient, and then you will see how much decrease of mean pulmonary artery pressure is there. So vasoreactive testing is positive if the decrease is more than 10 millimeter of mercury, and the final mean pulmonary artery pressure should be less than 40 millimeter of mercury. And during this testing, you should see that there should be no decrease in the cardiac output, because of vasodilation, the cardiac output could decrease. So that should not happen. And if all the criteria is fulfilling, it means that the vasoreactive testing is positive. So if patient is vasoreactive, then the choice of initial treatment here will be oral calcium channel antagonistic therapy. And if he is not vasoreactive, then there are two possibilities. So first, it would be the patient is having high risk finding like chest pain, syncope, or WHO function class 4, or patient is not having any high risk finding. So the main backbone of the therapy is ambrisentan and tadalafil. Ambrisentan, tadalafil, or macitentan or tadalafil. So ambrisentan and tadalafil is the common combination that we use in our OPD. So if the patient is not sick, then you will just continue on these tablets. And if the patient is sick, then it means that the patient is having chest pain, syncope, or WHO functional grade 4 or other high risk finding like very high proBNP more than 1100, or pericardial effusion, or decrease in cardiac output, that is cardiac index less than 2 liter per minute per meter square, or pulmonary vascular resistance of more than 12 Woods unit. Then here, apart from ambrisentan and tadalafil, you need to give IV or subcutaneous prostacyclin. This was also asked in the examination earlier. Now, talking about group 4 pulmonary hypertension. This is the special case, chronic thromboembolic pulmonary hypertension. So, here mostly we use warfarin lifelong for this patient. Although there are many research going on for NOACs also, but currently based upon Harrison, we give warfarin only. Then there will be multidisciplinary team which will be evaluating this patient thoroughly, like X-ray, chest CT, interventional cardiology, everything. And based upon that, you will take a decision whether pulmonary end arterectomy could be done for this patient or not. And if the patient is operable and you can do this procedure, that is pulmonary end arterectomy, then it has good lifelong survival benefit for this patient. And suppose if this could not be done and the patient is non-operable, then you can start the patient on the tablet of riociguat. This is soluble cgmp stimulator. This is the only tablet which could be started. Now coming to our last table. So from this table, this is the FDA approved therapies for treatment of pulmonary artery hypertension. From this table, I only need you to remember the route of administration. So the only medicine that could be given IV from here is epoprostenol and treprostinil. And the ones which could be given inhaled are iloprost and treprostinil. So if you see in this table also, the treprostinil is the only drug which could be given from all the routes. And apart from that, only IV is epoprostenol, and rest of the drugs are given orally only. From this, riociguat is important because it could be given in refractory CTE-PH.